patterns of established ill health and healthcare interactions, insights from the STEP survey. The STEP survey was carried out by the Ministry of Health and Wellness in 2023, utilizing a World Health Organization template, demonstrating just one instance of global to local, that connection within our healthcare system. So we will start this presentation with Rachel Corbett, the National Epidemiologist. She will provide information on results coming out of the STEP survey and insights. In her current role, Ms. Corbett is supporting the surveillance and reporting of both communicable and non-communicable diseases in the Cayman Islands, as well as strengthening the public health capacity. She will be followed by the Chief Nursing Officer, Felicia McLean, who was appointed earlier this year and joined the ministry with over 26 years of experience in nursing. Passionate about nursing excellence, Felicia is eager to lead initiatives to enhance professional development within the nursing profession and ensure the highest standards of patient care in the Cayman Islands. Last but certainly not least, the Chief Medical Officer, Dr. Nick Gent, will wrap up that session. Dr. Gent was appointed as CMO in October 2022 and has extensive experience working in areas including advice on legislation concerning human rights, public health, health services and health regulations, preparedness and response to major incidents, disaster relief coordination, restoring and developing public health systems, and developing healthcare services. The Cayman Islands and the medical community have benefited tremendously over the past 2 years from his experience. So that being said, I wanted to establish the credentials so you know the speakers who you're going to hear from have a great insight into the information that they're going to be sharing with you. So with that being said, I invite Rachel to start this presentation.
Good evening, everyone. With protocol having been established, I'm going to launch right in. My name is Rachel Corbett, and I'm the National Epidemiologist in the Ministry of Health and Wellness. And this is my third, and I think most exciting healthcare conference that I've had the privilege of speaking at, because we've got this data that we're going to be sharing with you this evening, which has been a huge endeavor, but a really exciting thing to be able to put together and understand much more up-to-date information of where the health of the population is currently at. So this work is all around, as you've heard, non-communicable diseases. And just to catch everyone up to speed, these are diseases which are not infectious. They're not passed from one person to another typically, but they are more so a result of a combination of behavioral and social, environment, and genetic factors. And a number of these can be examples such as cardiovascular disease, cancer, and diabetes. And these are the leading cause of mortality and morbidity around the world. And we see this echoed in the Cayman Islands mortality data from 2021 in the Compendium Statistics, which shows that cardiovascular disease is the leading cause of mortality here in Cayman, attributing to 27% of deaths. And diabetes is the third top leading cause of deaths, attributing to 10%. Not only is it a leading cause of mortality here, but NCDs can have a real impact on an individual's quality of life. This can impair their ability to do everyday activities, but also their ability in some cases to be able to work. For us to be able to prevent these, prevention is a really important part of what we do in public health. We need to understand more about the risk factors for non-communicable diseases and then target interventions at reducing those risk factors and therefore reducing the prevalence of the NCDs themselves. As I'm sure you're very aware, we also have an aging population here in the Cayman Islands, like many places around the world. And so will be indicating to us that in the future, our healthcare services will be facing a larger burden due to NCDs as NCDs increase in prevalence with age. So, a little bit of detail about the methodology behind the STEP survey. This is designed by the World Health Organization. It has a standardized approach, so it can be used in many countries around the world, and I think has been done in over 120 countries to date. It takes a random sample, so we don't interview or approach every individual in the population, and we approached 3,300 households. And we then weight the data in the analysis so that it then represents the population as a whole. Those who were invited to take part were eligible individuals who were residents, so we use the same definition as in the census, and between the ages of 18 to 69 years. A reason that we do this approach and go out into the population rather than just take data from healthcare facilities is if we did that, we wouldn't capture people who aren't in contact with the healthcare services. And this is really important to understand, especially when we're looking at access to care. And this has just been done once before, as was mentioned in 2012. So it's called the STEP survey because it has these 3 different parts, 3 different steps. The first one is the questionnaire. The second one is some physical measurements that are done at the same time as the questionnaire, includes things like height and weight and blood pressure. And then finally, step 3 is a finger prick blood test, very, very small amount of blood, that we then measure the blood glucose and cholesterol in. And that's done at a separate occasion by a nurse. And the risk factors that we then gather from all this information looks at things like tobacco use, alcohol use, physical inactivity, and diet, but also biological risk factors, things like whether an individual could be overweight or obese, have raised blood pressure, raised blood glucose, or abnormal blood lipids. So we're going to share these results you might have seen in the agenda across 2 different sessions, one this evening, which is looking at the established ill health, so covering things like raised blood pressure and raised blood sugar, and then tomorrow morning, we'll do a second session which will look at the determinants of ill health, some more of those behavioral type aspects. I'm first of all going to give you a little bit of a summary about the demographics of the individuals that took part, and then I'll launch into those items listed there. We have the prevalence estimates for the population as a whole, and then according to our sample design, we were able to stratify them by 2 different age groups, so the younger adults being those aged 18 to 44 years, and then an older adult age group of 45 to 69 years, as well as by sex, so looking at men and women. And through the slides, and as I talk, you'll hear me point out differences when we saw something interesting in the data between these different subgroups. And you'll also see on the slides some p-values. These are derived from statistical tests that we do to see whether those differences between the subgroups are statistically significant and therefore meaningful for us to take note of. So first of all, the demographics. We had just under 2,000 participants in the survey, and we had a pretty good split between men and women, slightly more women at 53%. Overall, half of the participants were black, 15% white, 11% Asian, and 8.5% Hispanic. It was quite interesting to look at the information on household income. So we ask a question about every individual who is earning in a household and how much their income is over the course of a year. And as you can see in that table, 20% of the population have an annual household income of less than $15,000, and another 21% have an income of $15,000 to $30,000. I was interested to see kind of internationally how different classifications of poverty work, and there is no universal definition, as obviously often the case in these instances. So I had a look at something that the UK uses called the Relative Low Income Indicator. And what they do is they look at the average earnings in a population. So they take the median income. They then look at what is 60% below that, and then that's the threshold they use to say that an individual has a relative low income. So I applied the same process to our data out of curiosity to see where it would come out. So taking the census data, from 2022. The median income at that time was just below $36,000 for the year. And looking at 60% below that came out just shy of $15,000. So taking that very financial approach to looking at an indicator of poverty, that would indicate that 1 in 5 of our population are living in poverty. Something else that was really interesting to look at was the health insurance data. So we asked individuals what type of policy they had. And 55% reported they had a local provider comprehensive plan. 17% reported that they were on a Cineco's plan. A further 17% reported they had a standard health insurance coverage plan. And then 5% were on a global provider comprehensive plan, and 5% reported no health insurance at all. So to launch right into the juicy bit, we first of all have some data here on raised blood pressure. So we asked the question of the individuals filling out the survey, have you ever been diagnosed with raised blood pressure? And 1 in 4 people said yes. When looking at how this split by age, this was significantly higher among the older age adults at 39%. We then looked at the measurements that we had taken from that step 2, and we found that 30% of the population either have raised blood pressure or are on medication for it. And again, this was higher among those in the older age group, 45 to 69 years, at 48%. So nearly half of that age group either have raised blood pressure or are taking medication to treat it. We also looked at the data to see how many fall into stage 2 high blood pressure. So the definition that we've used for this is having a systolic pressure of above 160 or a diastolic pressure of over 100. And this was 3.9% of the population are above this point and are not on any medication for it. We're just going to focus on this group here for a minute. So the 30% who we found to have raised blood pressure or be taking medication, and have a look at how, from their answers to the questions, how they're going through the cascade of care. So this chart here, you've got a series of bars. The first bar saying 100% represents all of that 30%. So if we think about the population size in the Cayman Islands, this works out to be around 16,000 people who either have raised blood pressure or are taking medication to treat it. We found in the second bar that 65% of those 16,000 are diagnosed, which means we've got a gap here of 35% who have not been diagnosed. We then found that 50% of the 16,000 are currently on treatment, which obviously means 50% aren't on treatment. But also, interestingly, 15% have been diagnosed but haven't made it that next step along the care pathway to be on treatment. And finally, we found that 27% are on treatment, and this is successfully controlling their blood pressure, which means we've got another gap here of the 23% who are on treatment, but this actually isn't effectively controlling their blood pressure. And so as I've been pointing out in these red text, these gaps along the care pathway, this is where we really need to target our interventions to make sure people are being caught at the right stages to get the right care that they need. There were also some marked differences for men and women in this data. So the chart on the left in the darker blue is representing for men, and the bar on the charts on the right for women. And you'll see particularly in that second bar, looking at the proportion that are diagnosed, this is much higher for women at 76% than men at 56%. So we've got 44% of men, nearly half of those with raised blood pressure are undiagnosed. And then this is a lot lower at 24% among women. And you'll see that all the way through the care pathway, there is a higher uptake among women. So in the third bars, looking at those on treatment, 60% of women are on treatment compared to 41% of men. So moving on to have a look at raised cholesterol. From the self-reported data, we found that 18% report that they've been diagnosed with having raised cholesterol, and around a third of those are currently taking medication to treat it. From the measurements we took from step 3, we found 32% to have raised cholesterol or be on medication, and again, this was significantly higher among the older age group at 41%. We also found that 6.2% of the population have got very high cholesterol. And from the self-reported data in the questionnaire, 36% reported that they'd never had their cholesterol measured, and this was higher among men at 41% than among women at 30%. Particularly interesting to have this data on cholesterol, as step 3 wasn't possible to report on from the survey that was done in 2012. There just weren't enough answers. So we've actually never had national statistics on the proportion of the population who have raised cholesterol. So a really great finding to be able to share. Something else that was added this time around to the survey that we didn't ask last time was about cardiovascular disease. Last time we did ask about family history, but we didn't ask about the individuals themselves who have experienced it. So from this survey in 2023, we know that 3.7% of the population have ever had a heart attack or chest pain from heart disease or a stroke. And as you'd expect, this is a little higher among the older age group at 5.8%. We also found that nearly 10% of the population are taking, 10% of those in the older age bracket are taking aspirin to treat or to prevent heart disease. So to move on to raised blood glucose, from the self-reported information, we found that 11% have been diagnosed to have raised blood sugar or diabetes, and the overall quarter of the population have never had this measured. Thinking about that 11% who have been diagnosed, we asked some questions to understand about the uptake of their care and how they're being monitored. And there are a few different indicators of that here in the bar chart. So first of all, looking at whether they've had 2 HbA1c tests in the past year, only 57% of those diagnosed have had that. Then looking to see who had had a foot examination relating to their diabetes, and 50% have ever had a foot examination, and 34% had had one in the past year. This was a very similar finding to the 2012 survey. Those numbers hadn't really changed very much. And then also for those that had had an eye examination, you'll know if someone has diabetes, they're at risk of diabetic retinopathy, and this is where the retina can be damaged and end up leading to vision loss. So it's really important to have eye examinations every year. And 70% had had an eye examination ever, and 60% had been in the past year. And this has increased slightly from the 2012 survey, which was 50% had had one recently. Then looking at the measurements that we took from step 3 around the raised blood glucose, we found that 7.8% of the population had raised blood glucose, were diagnosed and were on treatment, so we're in the right place for those people. A further 5% had been diagnosed but were not currently on treatment, and an additional 1.7% were unaware of the fact that they had raised blood glucose. And the final bit that I'm going to share tonight from the data is about body mass index. So BMI is a standardized tool that can be a helpful way at looking at the weight of the population as a whole. Like a lot of tools, it has its limitations, so it doesn't bear in mind muscle mass. So we use it as a helpful tool to get an idea, but it's not something to take too far with that. But in the green bars here, you can see the data from 2023, and we found that 2% of the population were underweight, 28% had a weight in the normal range, 37% were overweight, and 33% were obese. And if we combine those last 2 categories together, that tells us that 70%, 7 out of every 10 individuals in the population were either overweight or obese. When we then combine the 2012 data on the chart as well, just putting them side by side with the confidence intervals, you can see that not a lot has really changed. They're very similar levels, the confidence intervals overlap a lot. And if you take the final 2 categories for 2012, again, it comes out at 70% of the population being overweight or obese. So this really hasn't changed in the last 10 years. What is different for BMI, and this is the recent data from 2023, is looking at it broken down by men and women. So men are in the blue bars, women are in the orange bars. And you'll see that a significantly higher proportion of men are overweight at 41% compared to 33% among women. And then in the obese category, that a much higher proportion, 41% of women are obese compared to 25% of men. This pattern is actually exactly the same as in 2012. The numbers are slightly different, but the trend there hasn't changed either. So a couple of things to pull out as overarching themes from the information that I've shared tonight that really stands out to me. One being we have a notable amount of undiagnosed ill health in the Cayman Islands. And two is that people are not receiving the right care that they need, and we're losing them along those care pathways. And these are things that the Chief Medical Officer, Dr. Nick Gent, will be addressing in some of what we're proposing to put forward on the back of this data. The other thing that you've probably heard me say a few times in the last 10 minutes is that the numbers haven't massively changed in a lot of places. And I think what that makes me reflect on is, well, does that mean what we're doing is really working? And is it a good time to review what we're doing and making sure that our interventions are reaching the right people that need it? So a few limitations to bear in mind whenever we look at data. There are always things to be aware of. From the questionnaire data that was self-reported, there are a number of biases that come into play with self-reported data. So first of all, social desirability bias. When someone knocks on your door and asks you some questions, it's quite likely you're not going to be fully honest with them about things that maybe make you feel a little uncomfortable or maybe you're ashamed of. So that's one thing to bear in mind. Recall bias is another thing that comes into play. We ask a lot of questions which are about different time periods. So if we're asking about something recent, like the last week, it's much more likely that someone's answers are more accurate than when we're asking about the past year. And also non-respondent bias. So the survey was voluntary, people didn't have to take part when we knocked on their door. And it's likely that the individuals who said no maybe have less access to healthcare or less health education, so that's something just to bear in mind when interpreting the data. I'm really pleased that we managed to get a sufficient response rate for step 3 this time around to have national estimates. It's a huge achievement, but it wasn't quite as high as our response rate for steps 1 and 2. And what this means is that we've been able to stratify the step 3 data by those 2 age groups and by men and women, but not combine that together. So we have slightly less breakdown of that information. And one other thing to note is that mental health is also one of the key non-communicable diseases. We have not included that in this survey as we didn't feel it was the best way to be gathering that data, but that's something that we'll be looking at doing in other ways. It would be remiss of me not to take this opportunity to say thank you to a lot of people who worked incredibly hard to make this effort happen. As you've heard from the Minister, it was quite a big undertaking. I wouldn't be surprised if there are people in the room who were participants in the survey, and if you were, thank you very much for your efforts, for your time. We really appreciate it, and I hope from seeing the data you can see how valuable it is. As you've heard, we had a really big team of enumerators and nurses, and I've seen a number of them here tonight already, actually, who worked incredibly hard in the field and were very dedicated, so thank you very much for all your efforts. Our supervisors and our core ministry and the team worked tirelessly, not just when we were in the field, but many months either side, and did a tremendous job. And we had some amazing technical support from the Pan American Health Organization that we're really grateful for as well. There are a number of different stakeholders on the island who lent us their spaces to be able to do the step 3 appointments so that people could find somewhere on their way to work early in the morning to have that final part done. So thank you very much if you were one of those. And I also want to say thank you to our Honourable Minister who funded the survey and to our Chief Officer Nelly Pucci who sponsored the survey and really enabled us to make it happen. As you've heard, we're going to be launching the full report. It also has a fact sheet which is a little more accessible if you're not looking to read a full report, and some hopefully quite snazzy infographics that will all be on our website, which is www.gov.ky/steps. So keep an eye out for when that comes out. And I'm now going to pass to Felicia McLean, our Chief Nursing Officer. Thank you very much for your attention.
Good evening, everyone. Yes, protocol has been established, so we're going to jump right in it. Plus, we're running behind time a bit, so I've got a little bit of the fun, interesting part. So as you've heard, we wanted to look at the STEP survey. It happened before I joined the Ministry of Health and Wellness, which is a really good thing to have done in regards to getting a pulse of what our population has happening and what's going on. Now, I'm going to just remind us a little bit, as we mentioned the NCDs. What is that? What actually means by having high blood pressure, high cholesterol, high raised blood sugars, and those kind of things. So I'm just going to take us a little bit through the health things. So as you can tell, when you look at that established health and we talk about the things from the STEP survey, we looked at raised blood pressures, raised cholesterol, raised blood sugars. All of these things affect our overall health and wellness, and that's why it's so important to the Ministry of Health and Wellness to look at these stats. We're going to jump right in. There we go. And just talk a little bit about what it means to have a raised blood pressure. And the definition occurs when there's a force of blood against the arteries and walls is consistent or too high, placing excessive pressure on the blood vessels and the vital organs. So all you guys in the room know this, but high blood pressure, hypertension is what we're looking at. We also want to look at some of the physical effects of a long-term raised blood pressure. So when we look at our heart and we figure out that, we've had these going on, and we heard from the STEPS report that we actually have 25.7% increase in the number of people with raised blood pressures when we look at our survey from 2012 to our current one. And so it's definitely something that we want to address as a population. The increased long-term effects are going to give us stuff like heart attack, stroke, and basically when they're looking at these things, they're looking at the fact that whilst the blood pressure can go up and down over several months and days, if you have a sustained blood pressure for longer than 3 months, then you're going to have what we consider high blood pressure, and it's something we want to look at. Going on from there, I want to show you a couple of symptoms that we want to look at, because as we heard from the DG, and we're grateful that he shared his story, quite often we have symptoms, but we don't know it. Even ourselves as medical professionals, we can overlook it, or we think we know it all. So, shortness of breath, which might require you to cut back on activities, or you're taking the stairs and you feel a bit winded. It's things you want to pay attention to. Feeling tired, feeling fatigued, weakness, particularly in the legs when exercising, lightheadedness or dizziness, a fast heart rate, even when you're resting, and then that swelling in the lower legs. These are all things that we want to pay attention to in that regards to check our health. I want to show you a little quick video and hopefully get us into the idea of why it's so important to pay attention to these things.
My blood pressure was 182/100, and I had a heart attack and a cardiac arrest, and then a stroke. I was in total denial that there was anything going on wrong with my body, even though I was a nurse. I didn't pay any attention to the headaches or the dizziness my memory was kind of coming and going. I just thought it was because I was so busy being a mom. It's embarrassing that I didn't pick it up in myself, but my heart stopped and I was flatlined, and they had to resuscitate me, but it took quite a while. I went from running 25 miles a week to not knowing my children's birthdays. My oldest daughter had to raise my youngest, who was at that time 4. I mean, everything changed. It felt like my life was over. Then, somehow, I decided that I had to get better for my kids. And I dreamed that my memory will come back to what it used to be, and I'm doing everything that I can to make sure that it never happens, because I don't think I would survive the next one. Still, it's never going to be like it was.
So we can see there from this story, and this is one of a couple I'm going to show you as we go on, you don't expect it to happen. We walk around, we think we're well, we can pass off a lot of symptoms as that's normal, that's a part of life, but we want to pay attention, as DG said, to our body, to the signs. Our bodies is telling us stuff, and we see from our STEP survey that high blood pressure is something that our population is concerned about. It is something that we have happening. So let's keep going on, but I want you guys to bear in mind that high blood pressure does creep up, and it can happen to anyone. We're going to go on to high cholesterol. And when we're looking at that again, it's that buildup of plaque in the blood vessels, which would then affect the blood flow throughout our bodies. In the survey, we saw that there was a 32% increase of reported of that high cholesterol in our community. So this also is something we have to worry about and look at. And too much cholesterol can block those vessels and cause us to have the same kind of stuff as that heart attack or stroke problems. Some long-term impacts that were, sorry, we've gone ahead. Sorry. Some impacts of having the high cholesterol is obviously formulation of the plaques in the arteries, increased cardiovascular disease, and an increased risk for heart and stroke. I'm going to jump from there into blood sugars, mainly because this was another area where we didn't have step survey results for the last one, but it is big to know that it is the third leading cause of death in the Cayman Islands. So it's a big one again in our population, and a lot of it can be attributed to our very poor Cayman diet, and guilty as charged. I mean, I like to tell the story that when I married my husband and my family, I looked at my mother-in-law and said, you know, where's the vegetables in the meal? And she was like, the corn is in the potato salad. Like, that's the version of our diet. So you can see how a lot of carbs will play into our diabetes, and this is something else that's important in our community. So when we look at blood pressure, you know, high blood pressure or sugar levels, or high sugar levels can be a serious damage to our body, including our feet and our eyes. The thing with having raised blood sugars over a long-term time is going to affect so many parts of our bodies. We really want to look at keeping that in check. And tomorrow we're going to share a bit more about the diet changes that we could possibly put in place to help that. Well, let's look at some of the signs and symptoms of raised blood sugar. We want to pull out eyes. Eyes was another part that was captured in the STEP survey. And you see that the good thing is there are a lot of people getting their eyes checked, and that was something that went up as a positive number. People were getting the eyes checked more often, but it's something you want to watch because it will affect you. You can then have cataracts. You can then have difficulties, a retinopathy because of increased blood sugar. And it's something we don't tend to put together. You think, well, I ate a bit of sugar. As Dr. Gent loves to say, you know, you just have a touch of sugar. It's more than a touch of sugar. The long-term effects of that raised blood sugar is going to affect your eyes. It's also going to go along from there, and it can affect, obviously, our feet and nerves in our body. So we want to be paying attention to that if you're having those loss in feelings. There are lots of different signs and symptoms that come with that. It also increases our chances of a heart attack and a stroke. So they tend to partner together and intercalate in that regard. Diabetes also has, I was talking about the neuropathy, the symptoms that you're going to have, the muscle weakness, the pain, the numbness. All of these things come along with it. And then obviously one that we tend to overlook a lot is the gum disease, which also affects our health. A good oral hygiene is going to be better for your health than having issues with your gums, but it's something that we tend to just think about when we tell our kids they need to brush their teeth at night so that they don't have sugar in their teeth, but it's more than that. It's a buildup and a decay of our oral health that we want to pay attention to. I'm going to talk a little bit now about some of the symptoms that will happen because of a long-term high blood pressure or long-term high blood sugar or raised cholesterols. And as we saw in the video, stroke is one of the side effects that happen. A stroke can occur when the blood vessel to the brain is blocked and there is a sudden bleed in the brain. There are two types of stroke, as you know, ischemic as well as a hemorrhagic. And then some long-term effects of raised blood pressure on the brain. You'll see in there you have that lack of concentration, inability, and irritability with speech and difficulty. You have that lack of body awareness, increased pain perceptors, memory loss, auditory hallucinations, visual disturbances, and loss of coordination in that regard. So something we want to pay attention to. And also a stroke can be very life-changing. I'm going to share this video.
150/90. As a federal law enforcement officer responsible for deterring human smuggling, I felt absolutely bulletproof when the doctors told me to change my diet, go on medication, lower my stress levels, and I didn't listen. You know, just because you feel great doesn't mean that there's not a problem. November 5th, I got off work, went home, and I was playing catch with my oldest son. And then all of a sudden, I couldn't move my left arm. Turned out to be a full-blown major stroke. And then I had my second and third stroke. and followed into brain surgery to repair the damage. Very hard to imagine that I've been termed disabled. I've had to learn to swallow again. My memory is absolutely shot. The foot, I have no movement. Zero. That's, head to toe. Everything's changed. If I would have followed a treatment plan, I would not be in this situation. I was 40 years old.
40 years old is really telling. It can happen to anyone. We want to be aware of the signs and symptoms with stroke: sudden confusion, trouble speaking, or trouble understanding speech, that sudden numbness and weakness, especially on that one side of the body, sudden or severe headache, and sudden trouble seeing. These are things that we tend to forget or overlook, but the essence of a good survival rate post a TIA or potential stroke is fast and sudden response. So just want to remind people about that and paying attention again to these symptoms. Going to go on to another serious condition that can happen from long-term high blood pressure and diabetes, and we're looking at that kidney disease. That same high levels of sugar can cause the chronic kidney disease, which is basically when our kidneys are no longer functioning the way they should. And if it's happening over several months, then we're looking at kidney damage. There are several stages, 1 to 5 actually, and depending on how well our kidneys are functioning is going to depend then on where we're classed in that regard. But yet again, early detection, paying attention is our key. So some of the long-term effects of kidney damage. There we go. So we look in there, and we'll just look at a healthy kidney versus unhealthy kidney. You have your sodium, your water, and your hormonal production. Everything balances. But when they're not balancing, when we have a poor diet, when we have the raised blood pressure, it's going to constrict the blood vessels, and it's going to cause poor perfusion and poor management of the waste in our body. And then that's just a little bit of the stages in that regard. But the things that we want to pay attention to, if we are seeing symptoms of nausea, vomiting, loss of appetite, fatigue, weakness, sleep problems, urinating more often than or less, decreased mental sharpness, muscle cramps, swelling in the feet and ankle, those are other things. Now, obviously, all of these things can be diagnosed with our doctors, and so it's really important to have regular checkups. Go for our yearly checks, see what our blood pressure numbers are, see what our blood sugar numbers are, paying attention to our body and the signs and symptoms that we are feeling. Can you hit play on that one? It didn't play. We've tried to fix this earlier.
I was first diagnosed with kidney failure in my 20s, about 30 years ago. I was just shocked. It totally, your whole world changes. I planned to have children. I wanted to get married, and all that seemed to change, and I was told that I wouldn't be able to have children. So it was quite devastating at the time, and a lot to get my head round. I've been on dialysis 20 years. It was just really, really hard. I have dialysis 3 times a week for 4.5 hours, and that's Monday, Wednesday, Friday. And the only 2 days off guaranteed a year a dialysis patient gets is Christmas Day and New Year's Day. Actually, when you first start dialysis, I would say it takes 6 months to get your head around the fluid restriction and the dietary controls. I have 1 coffee a week as a treat. Potassium in food we have to watch because our kidneys don't work. So like chocolate, crisps, chips, shellfish, nuts, anything like that, jacket potatoes we can't have. A tomato is, like half a cherry tomato is an allowance. You have 2 ounces of veg that has to be boiled. So when you go out, it's so hard because you're literally looking at your plate going, well, if I eat that, I can't eat that bit. If I eat this, I can't have that. And that's what you have to learn.
I share that to say, like you, or myself for sure, and I'm sure many of you guys in the room, we look at obesity, and I wanted to tie this in here, and being overweight and it being a challenge to decide how to eat, or we go ahead and we indulge in extra cookies, or we indulge in the fast foods, or we indulge in the unhealthy Caymanian diet in general sense, and we don't think much about it, we carry on with our lives. But the side effects of long-term high blood pressure, the side effects of long-term high blood sugars can lead to kidney disease, could lead to the situation where you are sitting there on a daily basis looking at whether I can eat this or I can eat that. It makes so much sense for us to pay attention to our lifestyles from now, not having to wait till we have to do it because we've ended up with chronic disease like kidney disease or having a stroke, and then all of a sudden now we have to do it. Let's be proactive in making good decisions from now that are just going to affect our health in the long run. Some key takeaways. Long-term presence of these conditions, raised blood pressure, raised blood sugar, high cholesterol, and obesity is going to affect our overall health and wellness. We saw in the STEP study that obesity, or if we look at our BMI, it was 70%, and this has been the same for the last, we say, 10 years. It's crazy to think we've not made any difference in the overall health of our community when it comes to obesity or being overweight, and it's something we definitely need to do better. And so I'm excited about being in the ministry. I'm excited for this data, because now we can use that data to implement change, to look at creating a better Cayman Islands. Each condition can get progressively worse if untreated, but it doesn't have to be. These are things that we can treat, things that we can do in our lifestyles, or changes we can make that can make us healthier and better. I got one last video for you. Why should this matter to you? Oh, if it will play.
$180 over $111, and I had a stroke. I was diagnosed with high blood pressure 12 years ago. I had 6 mini strokes in the hospital, and I had a severe stroke 8 months later. That day was terrible. I passed out, and that's what I remember, passing out. When I woke up, I couldn't speak or walk. I felt trapped inside myself because I could think. I am an attorney, and I can't go into the courtroom because I think that most people don't find me intelligent. They tend to finish my sentences. And that's what I want to do. You have to be an advocate for your health. Because if you don't take care of yourself, this is what will happen.
So the Ministry of Health and Wellness is committed, as you heard from our minister, in ensuring that our community takes care of its health. And so as we look at the STEPS report, and as we hear a little bit more about some policies and we're looking at putting in place, I hope you guys are encouraged that we think that you matter, that we want you to take better care of yourself, and we want to help you on that journey, because we can have a better Cayman Islands. Thank you.
Good evening, ladies and gentlemen. And many thanks to my 2 colleagues for their presentation of the STEPS data and the overview of the health problems they reveal. Knowing about a problem begs the question, what do we do about that problem? To do something, we must understand the root causes, not of why these diseases exist, but why we are not recognizing, diagnosing, and treating them. Simply looking at the data and health consequences, I see ingrained faults in the way that we offer care, or more correctly, fail to offer care, and that this failure is affecting a very large number of our people. The first undeniable factor that we must fix is that of the impact of poverty, or more particularly, a manifestation of poverty. That is the fear of not being able to afford care. The undiagnosed number of diabetics and hypertensives show us that poverty is causing people not just to be selective about what care they can afford to receive, but often that they are choosing not to seek any care at all. The cost or fear of the cost of healthcare is now a major barrier to many people. It is especially apparent in the scale of the diagnosed but untreated numbers of hypertensives and diabetics. These are people who are knowingly taking a risk with their own health and fitness, but having to make that choice faced by more other pressing needs. But does cost really need to be a barrier to diagnosis and treatment? That is a critical question for us. Do we have a healthcare system that is fit for all? The Cayman Islands certainly does boast a very impressive secondary and tertiary healthcare system. The scale of installed technology alone to diagnose and manage illness would be impressive in a state home to millions, not tens of thousands of people. We have a physician to resident ratio that is amongst the highest in the world, but which only practically serves a small proportion of our people, those who can afford access to these systems. We have a very imbalanced healthcare system, one in which the systems that care for wealthier clients does so at the expense of the poorest. The wealthiest clients are diagnosed early, have optimized care, and avoid the inevitable complication of diseases such as diabetes and hypertension. The poorest present for care late, when the severest complications of chronic disease become manifest. The diabetic are often only being diagnosed and managed just prior to presenting with ischemic heart disease, renal failure, or peripheral vascular disease. The resultant cost to the state of trying to rescue patients at this stage is huge, and to be honest, we are fighting a losing battle at those stages of disease. So why is care for the poor so unaffordable? After 2 years of observing and assessing the care system, I could be critical of the insurance basis of treatment that is loaded towards treating illnesses in secondary and tertiary care settings, but limits primary care access. I could be critical of the skill mix amongst clinicians. This results in people getting treated according to the care that is available from a growing pool of tertiary specialists, but does not provide accessible care for chronic diseases to poorer patients. I most certainly can be critical of a system that encourages fee-driven behaviour, but I'm most critical of our failure collectively to care about this group of patients and to find solutions. Let us take hypertension. What is the true cost of care? Diagnosis is simple, or so it seems to me. A patient can even diagnose themselves with access to an electronic sphygmomanometer. But then modern medicine complicates the process with assumptions about best practice, often based on received wisdom, not evidence-based practice. I've listened quietly to conversations amongst clinicians, and not just in the Cayman Islands, where those clinicians would not proceed to treat a patient without a full blood count, metabolic profile, lipids, renal function, chest X-ray, 24-hour blood pressure recording, echocardiography, and an ECG. And while we're at it, let's do a CA125 or PSA test as well. That patient takes the forms, thanks you, and walks out of the clinic and past the phlebotomist because they cannot afford the care. They do not come back. We have closed the doors on them, and we have warned them that if you dare to come here again, you better have the money, or it will have to be a very serious illness. Worse still, we have diagnosed a perfectly easily treatable disease and abandoned their care because we have not tailored our response to their need and resources. And yet, if that patient had all those tests, what more information that is useful to the care of that patient have we gathered? I'm sure there'll be many people in the audience that will have a fund of anecdotes about the miraculous early diagnosis of a patient just because they took a scattergun approach to diagnosis and an unrelated abnormality was found. But that cost of that diagnosis was at the expense of all those patients that their standard of practice had excluded. Think quietly to yourself, if I've taken their blood pressure in a reliable way, done a dipstick test of the urine to give a reassurance about renal function and overt diabetes, and maybe a point of care test for cholesterol, what more did I really need to know to take control of the most important problem? And then look at the cost of treatment. If we did not have the overhead of the cost of diagnosing, prescribing, and dispensing, how much does it cost per day to control hypertension? If we adopted, for example, the PAHO Heart program in the Cayman Islands, the daily medicine cost would be between 10 cents for a single agent, up to 35 cents for a dual therapy with a statin. So that's between $40 and $125 a year. The cost of treatment is affordable. The cost of diagnosis and management is the unaffordable element. The PAHO Heart program now also includes a diabetes model, again paring back diagnosis to what is needed, offering phone app-based diagnostic support, and rational, affordable treatment planning that can be undertaken by a number of types of practitioners, not just doctors, as allowed under our new pharmacy law. Optimal care, best practice, gold standard, these are all phrases that, while sometimes well-meant, are defeating the real purpose of a healthcare system, that is to give care, not providing care because it does not meet someone's idea of optimal care is not responsible care. Cost-effective care is not second-rate care. In the case of hypertension and diabetes, optimal care is actually very affordable. The sadness of what these data reveal is that a lot of our people in the Cayman Islands are not receiving what is in truth affordable care. We must look at ourselves more closely and ask, are we really serving our people as we continue to innovate for people with money and yet cannot find a way to manage the two most significant health problems found in the poorest amongst us? Thank you.